Hi, my name is Dr. Mahsa Mohebtash. I am the medical director of Franklin Square Cancer Center at Loch Raven. Today I'm talking about monoclonal gammopathy, and please post your questions on the comment box and I will answer them once finished. Thank you. So what is monoclonal gammopathy? Monoclonal gammopathy has two other names: plasma cell dyscrasia or paraproteinemia. It is caused by proliferation of abnormal clone of plasma cells or B cells. It includes a wide variety of diseases. Actually, it can be a spectrum. It can be symptomatic or asymptomatic. So in this picture, we see plasma cells. That is how they look, and it's a picture of bone marrow aspirate. Plasma cells produce immunoglobulins, which consist of two heavy chains and two light chains. When they become clonal and expanded, they produce monoclonal proteins, which can be a whole immunoglobulin or just light chains. Light chains can be kappa or lambda light chains. So what is multiple myeloma? Multiple myeloma requires more than 10% plasma cells infiltration in the bone marrow or biopsy-proven tissue plasmacytoma, plus one of the following. It's very important to know that it has to be an end organ damage involved in multiple myeloma, besides having 10% of or more of plasma cells. End organ damages are hypercalcemia, renal insufficiency, anemia, lytic lesions, or as abbreviated as CRAB, to remember. So there are some other criteria or biomarkers which are associated with near inevitable progression to end organ damage. And that's when you have more than 60% plasma cells in the bone marrow. It's very unlikely not to have end organ damage with this level of plasma cell infiltration. And the free light chain ratio, if it's more than 100, it's very unlikely that you do not have any end organ damage, or it's going to be very soon. MRI with more than one focal lesion involving multiple areas of bone or bone marrow, these are also suggestive of multiple myeloma. What is a smoldering myeloma? Smoldering myeloma is that when you have a large M protein, which is usually more than 3 grams, or 10 to 60% of bone marrow infiltration of plasma cells, plus there should not be any end organ damage in smoldering myeloma. And the light chain ratio should be less than 100, and there should not be MRI or other imaging finding of more than one focal bone lesion. Waldenstrom macroglobulinemia. So multiple myeloma, it's either IgG or IgA, kappa or lambda, rarely IgD. When it is IgM, monoclonal gammopathy, it is Waldenstrom macroglobulinemia or IgM MGUS. So when you have IgM monoclonal gammopathy and lymphoma infiltration in the bone marrow, that defines Waldenstrom macroglobulinemia. Symptoms are either related to the infiltration of tissue, which causes anemia, lymphadenopathy, hepatosplenomegaly, or effects of monoclonal IgM in the blood with hyperviscosity and peripheral neuropathy. We have an entity of IgM multiple myeloma, but that is extremely rare. So solitary plasmacytoma is tumors which are composed of plasma cells, and usually there is no bone marrow infiltration. Actually, there must be less than 10% of bone marrow infiltration. Very rarely you see solitary plasmacytoma with MGUS, but in general it's just one area infiltrated with plasma cells. Unlike multiple myeloma, which is not curable, solitary plasmacytoma could be cured with radiation and local treatment. If solely it is in the bone, it is called solitary plasmacytoma of bone. If it's in soft tissue, it's called solitary extramedullary plasmacytoma. So as I said, it has to be 4 criteria to be met: biopsy proven, solitary lesion of the bone or soft tissue showing clonal plasma cells, normal bone marrow with no evidence of clonal plasma cells, and sometimes you can have minimal marrow involvement if clonal plasma cells is less than 10%. And the MRI and PET scan and other imaging is normal except for the primary solitary lesion. You should not have evidence of anemia, hypercalcemia, renal insufficiency, which are the signs of end organ damage. So light chain or AL amyloidosis. In AL amyloidosis, which is also called primary amyloidosis, monoclonal light chains, they form fibrils, which lead to end organ dysfunction. They stain with Congo red, and there should be less than 20% of marrow with plasma cells, no lytic lesions on imaging, and diagnosis is made by biopsy of the affected tissue. One thing to remember about amyloidosis is that amyloidosis does not have to be systemic. It could be organ limited. It could be involving 1 or 2 organs. So it's best if you can biopsy the organ which is involved. So usually it is abdominal fat, bone marrow, rectum, kidney, and endomyocardium that we biopsy. Rarely, multiple myeloma can develop in patients who have primary amyloidosis, usually in patients who do not have cardiac or hepatic involvement and who can live long enough to develop multiple myeloma. Conversely, the development of dipstick positive proteinuria. So remember, dipstick urine analysis does not detect Benz-Joyce protein, does not detect M protein. It only detects albumin. So if you see in a multiple myeloma patient that the UA becomes positive, their albumin drops, or there is edema or heart failure, suspect light chain amyloidosis or light chain deposition disease. So what is light chain deposition disease? It is, again, deposition of light chains in tissues, but the difference between light chain deposition disease and light chain amyloidosis is that light chain does not bind to Congo red and is usually predominantly affects the kidneys. If it affects glomerular structures, they can present with nephrotic syndrome. If it predominantly affects tubular structures of the kidney, they may present with renal insufficiency. So like amyloidosis, light chain disease can be associated with multiple myeloma or other conditions like lymphoma or Waldenstrom. Heavy chain deposition disease is very rare, and it's production of M protein just consisting of the heavy chain or a portion of it without bound light chains. So there are 3 types of heavy light chain, and it's based on the class of the immunoglobulin heavy chain it's produced, and it could be alpha, gamma, or mu. Diagnosis is by immunohistochemistry of the affected organ biopsy, which could be a mass lesion, lymph node, or bone marrow, which shows clonal population of B cells staining positive for heavy chain, but negative for kappa and lambda light chains. Poem syndrome. It's rare, but it's important to know because it can be very confusing. We all hear that multiple myeloma can cause lytic lesions, but the lesions here is osteosclerotic. So that's why some people call it osteosclerotic myeloma. It consists of polyneuropathy, organomegaly, endocrinopathy, monoclonal protein skin changes. The cause of Poem syndrome is unknown, although overproduction of inflammatory cytokines seems to be playing a role. And peripheral neuropathy is definitely required for this diagnosis, and usually dominates the clinical picture. You should suspect it in a patient with polyneuropathy and evidence of a monoclonal plasma cell disorder. The diagnosis of POEM syndrome requires the presence of both criteria, which are mandatory: monoclonal plasma cell disorder and polyneuropathy, plus at least one major and one minor criterion. And the mandatory criteria, both are noted here. Major criteria is either sclerotic bone lesions, Castleman disease, or elevated levels of VEGF, vascular endothelial growth factor. Minor criteria is organomegaly, which are splenomegaly, hepatomegaly, or lymphadenopathy. Extravascular volume overload like edema, pleural effusion, or ascites should be present, but it's a minor criteria. Endocrinopathy in POEM syndrome excludes diabetes, and it's usually adrenal, pituitary, gonadal, or parathyroid. Skin changes, it's commonly seen in this syndrome, which is usually with hyperpigmentation, hypertrichosis, and plethora, acrocyanosis, and flushing. Papilledema sometimes is seen, thrombocytosis and polycythemia are also sometimes seen. So this is a picture, skin changes of a patient with POEM syndrome. You can see the skin lesions here, which is papules which are erythematous, and some hyperpigmentation here associated with maculopapular lesions. Cryoglobulinemia is also one of the monoclonal disorders. However, only type 1 and type 2 can be monoclonal, and it's a disease in the serum that precipitate at a temperature of less than 37 and redissolve, the cryoglobulin redissolve when they are rewarmed. Signs and symptoms are related to vascular occlusion by cryoprecipitate, which could be digital ischemia, livedo reticularis, skin necrosis, or purpura. There could be constitutional symptoms: fatigue, arthralgia, myalgia, weakness, or peripheral neuropathy. Remember, when you are checking for cryoglobulins, you have to make sure the temperature is warm on the tube, so the tubes are warm, because if it goes below 37, you will get false negative results because they are going to precipitate. As I said, there are 3 types of cryoglobulinemia. One is type 1, which are monoclonal immunoglobulins, usually IgG or IgM, and less commonly IgA or free light chains. And it's in general in the setting of monoclonal gammopathies like MGUS, multiple myeloma, or Waldenstrom, or chronic lymphocytic leukemia, CLL. Type 2 is a mixture of monoclonal and rheumatoid factor activity and polyclonal immunoglobulins. And it's in general in the setting of viral infections, particularly hepatitis C infection. It could be also hepatitis B, HIV, and autoimmune diseases, especially lupus and Sjogren's syndrome, and some lymphoproliferative disorders. Type 3 is mainly polyclonal. It's a mixture of polyclonal IgG and IgM, and it's a setting of autoimmune disorders and sometimes hepatitis C. So now we are going to talk about MGUS, which is a monoclonal gammopathy of unknown significance. This is something that is usually diagnosed by primary care physicians, and it's very common. More than 3% of the general population over age of 50, they can be diagnosed with monoclonal gammopathy of unknown significance. It's more common in men. It's more common in African Americans. And it's usually an incidental finding. And it's when physicians are checking for other diseases like workup for anemia, or they find a lytic lesion, or they see chronic kidney disease, they want to work it up, they come across this diagnosis. It is asymptomatic, pre-malignant, clonal plasma cell or B-cell proliferative disorder. It's defined by serum monoclonal protein of less than 3 grams, bone marrow, which has to be less than 10% monoclonal plasma cells, And this is the most important thing, absence of end organ damage. There should not be any CRAB criteria, lytic lesions, anemia, hypercalcemia, renal insufficiency, or hyperviscosity. A bone marrow evaluation can be deferred. Like if you are not sure, always go with bone marrow biopsy. But if the level of M spike is less than 1.5 and it's a low risk, it's IgG and not IgA, and light chain ratio is normal, then you can defer the bone marrow biopsy and watch the patient. But be careful that if you have any suspicion that this can be something more serious, because 4 to 5% of multiple myelomas are oligosecretory or non-secretory. It means that they do not produce that high M protein. So you may miss it. So if there is unexplained anemia, unexplained renal insufficiency, just do not go by the number of M protein. And sometimes it could be just light chain disease. So if you don't check the light chain ratio and the light chain ratio is very high or very low, you may miss the diagnosis of multiple myeloma. So there are 3 types of MGUS. One is non-IgM MGUS, which is most common subtype. It can progress to smoldering or symptomatic myeloma, less often to AL amyloidosis or light chain deposition disease. IgM MGUS is about 15% of MGUS cases can progress to smoldering or symptomatic Waldenstrom macroglobulinemia, and less often to amyloidosis or lymphoma. Light chain MGUS is secreted M protein, lacks the heavy chain, and can progress to light chain myeloma or amyloidosis or light chain deposition disease. So we said MGUS doesn't cause end organ damage, but what are the risks associated with MGUS? So MGUS can progress to multiple myeloma at the rate of 1% per year. So that's why it needs to be monitored. It increases the risk of peripheral neuropathy, and the mechanism of peripheral neuropathy in monoclonal gammopathies in general is not well understood, but MGUS is a risk factor for that. It doesn't cause lytic lesions, but in the studies it has shown it increases the risk of fractures at 10 years with a hazard ratio of 1.6. So it is greatest for axial fractures. The risk does not differ by isotype of IgG or IgA, or even interestingly, M protein concentration at diagnosis. Fractures do not predict disease progression. And that's why we recommend DEXA scan and checking for vitamin D in patients with history of MGUS. It's also associated with a small increased risk of venous and arterial thrombosis, and the mechanism is unclear, but hypercoagulable state secondary to ongoing clonal plasma cell expansion and activity has been suggested as an explanation. There is an increased risk of malignancy in patients with multiple myeloma and MGUS, and they do not recommend any extensive workup for malignancy, just age-appropriate cancer screening program. So how do you manage MGUS? It can progress to myeloma at 1% per year. Rate may be slightly higher for IgM MGUS and slightly lower for light chain MGUS. Median survival of patients with MGUS is only slightly shorter than at the age of the matched controls. No treatment is required, and usually annual or biannual, twice yearly protein electrophoresis, serum free light chain, CBC, creatinine, and calcium, and HMP is needed. Risk of progression for low risk non-IgM MGUS, which is M protein of less than 1.5 and IgG subtype, and normal light chain ratio is only 5% over 20 years. So you can screen them and monitor them at the longer intervals. So when should we screen for monoclonal gammopathy? When you have unexplained symptoms and signs of peripheral neuropathy, pathological fractures, Raynaud phenomenon, and acrocyanosis, hyperviscosity symptoms, heart failure, which is unexplained, or peripheral edema, which is unexplained. When you have unexplained laboratory and imaging findings, it could be normochromic anemia, high SED rate, elevated serum viscosity, elevated total protein, proteinuria, hypercalcemia, osteolytic lesions, recurrent infections, hypo or hyper gammoglobulinemia. How should we screen for monoclonal gammopathy? You need only 3 tests to screen for monoclonal gammopathy. You only need serum protein electrophoresis, serum immunofixation, and serum light chain. You can replace serum light chain with urine electrophoresis. Once one of these become positive, then you have to go to the second line and do more workup. You have to collect 24-hour urine for protein electrophoresis and immunofixation, CBC, creatinine, calcium, and immunoglobulins, IgG, IgA, IgM levels. And then you have to confirm the diagnosis with a bone marrow biopsy and aspirate, if needed, again, depending on what type of MGUS you run into, bone imaging, fetal survey, PET scan or MRI, echocardiogram, or if needed, cardiac MRI. Thank you for listening to my presentation. Please don't forget to put your questions in the comment box and I will respond to them. Thank you.